Hi, I'm Dr. Donald Jurovich from the University of North Dakota Department of Geriatrics. Today, I'd like to present one of two micro lecture modules on the geriatric 4M of medications. As a reminder, this program is supported by HRSA through the Geriatric Workforce Enhancement Program initiative. So the goals of this presentation are to consider the risk factors that are specific to older adults. We want to reinforce the concept that polypharmacy is hazardous and unsafe, and we would like to deal or understand what the barriers are to deprescription, both from a health systems point of view and from the patient's perspective. So I think it's important to understand why we practice the 4Ms as a set. And mainly it's because one of the 4Ms interfaces with the other three. And you can see here how medications might influence what matters, certainly mobility with the risk of falls with certain medications, and then also mentation, knowing that medications can cause delirium and other side effects such as memory loss, and the new data that's suggesting that long-term use of PPIs might be associated with dementia. So again, it's important to consider what the interface is with each of the 4Ms with one another. So the issue that we need to concern ourselves with in terms of evaluating medications is always this balance. You know, it's the Hippocrates motto of first do no harm. And so we always want to be on the left side of this curve here where we're maximizing benefit and reducing risk. Sometimes we know that some of our best interventions still may lead to harm, and that's always a delicate balance to consider. So for example, if we add an additional SSRI for treating depression, we also increase the risk of falls. So again, it's always a risk-benefit ratio that we need to be mindful of. There's some conundrums in deprescribing. Part of that is that we're having a population that's living longer, while at the same time the trained workforce in geriatrics is pretty much static. In fact, there are fewer geriatricians now than there were 10 years ago. There's also this consideration of drug safety amongst increasingly vulnerable older adults, and so these medications continue, and as the older adult may have a functional decline or a decline in renal function, the medications are not adjusted on a regular basis. We don't have perfect deprescribing guidance, and I'll share with you a couple of websites that will be resources for ongoing research related to the deprescription process. The other point is that a lot of clinical trials just don't include older adults, and I'll show you an example of that here in a minute. Certainly, we know that pharmaceutical industries don't have a incentive for studying vulnerable or frail older adults. And importantly, there really are no robust guidelines for how to handle medications when there are multiple chronic conditions. And so you can only imagine that when people have 5 chronic conditions and you have even maybe 1 or 1.5 medications per condition on average, you have already entered the realm of polypharmacy. And so there's assuredly some drug-drug interactions that occur as a result of having to treat these multiple chronic conditions. Yeah, so here's a good example of enrollment. So you can see that the 75 and older age group had very low representation in an oncology study for this clinical trial compared to a younger population. So that just reinforces the concept that we don't have a lot of strong evidence about what side effects certain medications, and so that's one of the issues even with this new Alzheimer's medication called lecanemab, where the average age was much younger than you would expect to see in clinical practice. So I think the kind of 30,000-foot view here is that we have to understand that older adults range from quite healthy, robust individuals at all age groups. And again, at all age groups, there are a certain percentage of frail and vulnerable older adults. And as they approach that frailty time period, the older adult becomes increasingly vulnerable to various stressors, and those stressors might include medication burden, medication side effects, so that they become more intense, if you will, as a result of the functional decline that people experience. And certainly this is true in the final 2 to 3 years of life, that people become intensely vulnerable to different side effects. And that's why we see a lot of delirium in hospitalized patients as a result of their perhaps medication baseline that includes one or more anticholinergics. So we always need to be mindful of the dreaded and somewhat insidious adverse drug effect. They are clearly under-recognized by multiple research studies. A lot of times the symptoms are attributed to disease rather than medication side effects. And many, many times this leads to additional treatments to treat the symptoms of drug side effects. So you can see the vicious cycle of the dog, or the wolf in this case, chasing its tail. So we might want to consider what the adverse drug events might be, and what are the risk factors. So certainly oldest old, those who are over 85, are more susceptible. Polypharmacy for sure. More than 6 medications have 100% certainty of having some type of drug-drug interaction. Those who have low kidney function, particularly those in stage 3 and 4, chronic kidney disease. Can't underestimate the issue of multiple prescribers. One study demonstrated that there were as many specialist visits as there were primary care visits in a ambulatory care clinical practice. Low BMI and frailty are predisposition to drug side effects, as well as multiple chronic conditions. Kind of a caveat here about blind adherence to guidelines. So we know that, for instance, spironolactone is not a good medication on heart failure for about a third of older adults, mainly because of reduced renal function, and it causes hyperkalemia. There are also well-known high-risk medications, and that's why we put so much emphasis on avoidance of anticholinergics, such as muscle relaxants and first-generation antihistamines. So this is a somewhat vivid example of research that demonstrates how side effects escalate with the number of medications. And so you can see in the middle here, the probability of a drug-drug interaction increases from a 50%, which is pretty high rate from the get-go when you have 5 to 9 medications, up to 100% interaction with those who are on 20 or more medications. And you can see what the bad outcomes are. And so obviously death is a potential outcome, which could be from delirium. Delirium carries a certain mortality rate. Falls, they often indicate that falls result on 10% of the time of serious injury, of which there's a percent of mortality associated with that. And certainly disability resulting either from falls or cognitive changes. And then this is kind of an interesting concept here about the induction of or the promotion of frailty as a result of polypharmacy. Clearly a reversible element for avoiding frailty, if we think about it. So the issue that we deal with medical complexity is that we get into this red zone here of sometimes inappropriate medications, certainly the number of medications, make a difference, and then this whole concept of a tight adherence to disease control. And while we have over the years have, for instance, loosened up our guide for hemoglobin A1C and diabetes as an example, there are still individuals who seek tight control of their blood sugars, and so there's always that question of inducing hypoglycemia. And there's other examples where, again, following best practice guidelines may not always be in the older adults' best interest. So we need to consider some of the barriers to deprescribing. I think for a busy clinical practice, there's just not always enough time. Also, in terms of continuing medical education, this whole issue of deprescribing doesn't always come up on the radar, and so there may not be opportunities to reinforce the concept or to do a deeper dive into processes of deprescribing. Certainly number 3 here about the patient's insistence on taking a medication. One time I tried to deprescribe an antipsychotic on a older adult in a long-term care facility. He says, "Oh, he says my psychiatrist gave that to me," and he says, I've been on it for I don't know how many years, 30 years, and it was like lock and key, and I couldn't find a reason why he needed that medication. But again, he had bought into it and thought that his health was dependent upon it, so he was resistant to deprescribing. The other and final point that I want to make here is just the difficulty that we have with, and the time, quite honestly. I don't know if it's the logistics as much, but just communicating with other prescribers. And a lot of times I will send a message to, for instance, cardiology, when I mention to them that the dual beta blocker and alpha blocker is causing hypotension in an older adult. And so, for instance, we might be switching terazosin with finasteride for prostatic hypertrophy. So the other conundrum, if you will, is this whole issue of who's got the prescriptive authority. I just wanted to share with you that I was part of a deprescription process in long-term care for reducing antipsychotic burden. And almost uniformly, the medical directors and primary care providers said, well, these drugs were prescribed by our consultant psychiatrist, so I don't feel confident or that I would have a role in the deprescription process. And so I think it's important to understand that we do have ownership, particularly in primary care, for those medications. And if it does require a consultation, a message, a phone call, or whatever to reassure that your deprescription process makes sense with the consultant, then I think we're obligated to promote that approach. Some of the other barriers are, as we can see here in the list, for deprescription blockades, if you will. The middle one I think is quite important, and just to reinforce the issue of how the prescribers may be reticent to reduce medications, and also side effects. I mean, sometimes you might just deprescribe a PPI, and then a couple of weeks later, the individual shows up in the emergency room with an acute GI bleed, and it makes you wonder cause and effect, despite the fact that there was no clear evidence, for instance, for using the PPI other than for perhaps a past history of reflux that had resolved. So anyways, that's just, I think, a good example of how there might be provider fears. And then also with the patient, they view that the medication was given to them by some expert, and why are you taking this away from me? Are you the expert? So to summarize our considerations here, we want to recognize the fact that aging is a clear risk factor for medication-induced adverse events. We know that individuals who are on 5 or 6 or more medications that there's a strong likelihood of drug-drug interactions that we need to be mindful of. Part of the problem with deprescribing is this fragmentation of the system and episodic nature. And so again, it reinforces the concept that with each clinical encounter, when we practice the 4Ms, that we include a medication review of not only the medicines that we prescribe, but also the medications that the older adult may be taking as over-the-counter, or using medications of somebody else's, either a spouse or friend. We need to be mindful of the crossover between providers and the barriers to deprescribing and enhancing our communication to solve that. And also, we need to sometimes consider the trying to break down the psychological barriers, if you will, to deprescribing that exists with patients who have been long-standing users of a particular medication. And that's particularly true with opioids and benzodiazepines, as we know. And then also, and finally, perhaps the strongest point here is to consider what the medication impact is on the other 4Ms. Is it really making a difference in what matters to the older adult? And is that statin in an 88-year-old increasing the medication burden and making their life more difficult because they're taking so many medications? And perhaps that's an opportunity to ask if deprescribing that medication might make a difference and simplify the regimen for the older adult. So with that, I want to thank you for your attention, and we will have a part 2 to this series of the 4M of medications. Thank you.